pharmacists and nurses. And then Anna approached me, okay, you're going to have a CSA. So I don't know what will be the audience. So it's very difficult for me to prepare. So to cover these wide ranges. So I try to be more conceptual rather than objective. So that's why I choose the term liver-miscellaneous. So if there is something query or if you're not clear about it, anytime you can raise your hand and ask any questions. Today will be, so this is jointly sponsored by PKSH, the 911, B and ANA. My contents will be conceptual approach on liver structure and function. As you all know, the liver is, everybody here, most of the junior doctors, they are quite afraid of hepatology. They say it's a boring subject, or it's just very hard to understand, or something like that. So I try to clear as much as I can, because that's why I will be saying about the concepts. And I will be talking something about protein disturbances in chronic liver diseases. So because we are leading from the KSH at 911, so I have to cover that. I will be telling on protein metabolism and cirrhosis. And then I will be talking about the future of hepatology, or what our future medicine will be like. And then something about my foundation, that is GI Liver Foundation, and our activities in brief. So this is the liver. So I won't take much time on liver. This is the inferior cervix. So the liver is the largest organ in the body, if you take it as an internal organ. But if you take skin as an organ, then the largest organ is the skin. And the liver will be the second largest organ. So liver has a lot of functions. There are approximately 550 functions of the liver. So I can't touch every detail of the liver function. These are the common functions of the liver: metabolic, storage, synthetic, secretion, excretion, and then the most important thing is the inactivate detoxification function and defense functions. So liver is a metabolic organ, and the storage function, nothing much. Vitamin A, D, and B12 is stored in the liver. What metabolism is involved in normalizing the blood glucose level? Whether you are in a fat state or whether you are in a fasting stage, the blood glucose level within a small range, normal range, the liver is doing. So if you eat up, you get a much glucose. So you don't want to have the blood glucose level gone up. So the liver buffered it by storing it into excess glucose into glycogen or convert it into fat. When you are in the fasting stage, when the blood glucose level is low, they tend to raise the blood glucose level by gluconeogenesis. That is, they use up the glycogen, stored glycogen as a glycogenolysis or gluconeogenesis. You break down protein and fat or glucose. And then the synthesis of fat, the lipogenesis through acetyl-CoA pathway, and then Krebs cycle, and then you metabolizes as glycogen into glucose again. Or we can use ketones as for instead of glucose when there is a shortage of mass shortage of glucose, that is gluconeogenesis. Before fat was breakdown, proteins are breakdown fast because we had a glucogenic amino acid which we can directly transform the protein into amino acid into a glucose. So that was first used. Then we use fat. As you all know, protein, there is no extra protein in our bodies or a storage protein. Every protein, a single protein is all used up in the body. So for fat is also a protein sparing action. Protein is too valuable for energy production. So we use fat as energy. And we had a lot of fat to use as energy, as ketones. The synthetic function is we synthesize plasma proteins, except immunoglobulins, clotting factors, complement factors, hormone binding proteins, the carrier proteins. And we also synthesize steroids and heparin. And then bile synthesis is done by the liver. Excretory function, liver excrete cholesterol, biopigments, heavy metals, xenobiotics. Whatever you eat, you have to pass the liver. And the liver metabolizes it into or detoxify it. That means fat soluble, they turn fat soluble subjects into water soluble ones so that they can be excreted in the urine. And heat production, one of the metabolic function of liver. And hematopoietic function. The liver produces red blood cells, so that's why in thalassemia you get this hepatosplenomegaly. And it stores vitamin D, B12. And in hemolytic functions, usually the lifespan of RBs is 120 days and they are destroyed mainly in the spleen. But in the early part of our life, liver also do that function by buffer cells in the liver. And inactivation of hormones and drugs, detoxification. Everything you eat for energy value, for nutrient value, other than nutrient value, we call it xenobiotics. All the xenobiotics are handled by the liver to become a harmless subject or effective subject. The defense. Liver is one of the most important defense organisms because it is quite close to the GI tract where we have kept all the bacteria to help us in the digestive process. So, if they are leaked into the portal circulation and when they arrive to the liver has to handle all these microorganisms. So, the liver has to be immune tolerant because if they become immune active, because the organisms are passing every day or each and every hour, so if they are active, then liver will be inflamed throughout the whole life. So liver tends to settle down this immune process by immunomodulatory effect. That's why in liver, the chronic infections like viral hepatitis B and C are more common. This is a detoxification by phases, okay? And another thing is protein metabolism, deamination of amino acids, formation of urea, and formation of plasma proteins, and then in the conversion of amino acids. The plasma protein, everybody knows that now they are for oncotic pressure and then for carrier proteins. It is a function of the liver to produce all these proteins. This is a short view of. So this is to meet that functions. Liver is structured like this. So liver is got the portal flow from the spleen, from the digestive tract, all pass through the liver. So all the one you have eaten, or nutrient value or non-nutrient value, whatever you eat, whatever pass through the mouth has to pass through the liver after absorption from the intestine. It is liver is structured like this. If you look at the blood supply of the liver, only 20-25% from the hepatic artery. The remaining 75% is from the vein, the portal vein. In the body, all the organs are supplied by artery and drained by vein. In the liver, only 20% is supplied by the hepatic artery and majority is from the portal vein, because all the nutrients or everything you eat from the intestine has to pass from the portal vein into the liver before the body can use it. And the functional unit of liver is not the hepatocyte. The functional unit of the liver is what you call is a hepatic lobule. Hepatic lobule is made up of, in the center is the hepatic vein and the portal triad, and in between are the cords of hepatocytes. If you look at it, so this is the portal triad and this is the portal vein, and the venous blood passes through the sinusoids into the hepatic vein. You can see hepatocytes beside these sinusoids. So the nutrients or the xenobiotics, everything can be passed easily from the sinusoids into the hepatocyte, and the hepatocytes will do the function what I mentioned earlier. And this is a structure of the liver so that he can do his 550 functions of the liver. And for the drug metabolism, this is a bit important, because here is the portal triad, here is the hepatic artery and the portal vein. So the nearest to the portal triad, they got more oxygen and they got more work to do with the nutrients. And the zone 3, the furthest from the portal triad and the nearest to the hepatic vein, this is the zone 3, has less oxygen and less, this is the area of biotransformation of drugs and chemicals and toxins. And it is more sensitive to ischemic changes because it is furthest away from the oxygen supply. And another thing is the formation of eye salts and biopigments. And then the biosalts helps in the digestion of fat in the GI tract. And the bilirubin, we have to get it is toxic to the body, so we have to eliminate the bilirubin. Actually, we have made the bilirubin fat soluble, water soluble, but we can eliminate it through the kidney. But majority of the bilirubin is eliminated in the bile. So in summary, this is the formation of the liver. The liver is formed by these liver lobules, which is made up of hepatocytes, portal triads, hepatic vein, and the relationship of the hepatocyte the sinusoids, which is drained by the portal triad into the hepatic vein. This is the most important thing, the structure. In cirrhosis, there is a liver damage, there is a dead hepatocyte, and dead hepatocytes are replaced by new hepatocytes. They are replaced by new hepatocytes, but the relationship of the portal triad, sinusoids, hepatic vein, and sheets of hepatocytes, this structure is damaged. So that's we call it a regeneration nodules. Regeneration nodules are more hepatocytes. They don't have this structural relationship. So even we had a hepatocyte, the liver can't do its function properly in chronic liver disease and cirrhosis. So that's why the structure is important for the function. This is a clear view of this. So this is the sinusoids, and this is the space of Deci, the space between the hepatocytes and sinusoids. If you look at the sinusoids, it is a thin layer of epithelial cells. Unlike capillaries, these sinusoids, they don't have a basement membrane, and they have pores so that the nutrients can pass easily into the hepatocytes. For immune function, these cover cells are lined with these sinusoids. And the space, in the space of Deci, there is what we call it SAC, stellate cells, and then there is a matrix containing collagen. But these collagen are thin fiber collagens, unlike dense collagen in cirrhosis. This is a normal. You can see the pores, big pores with little collagenous tissue matrix in the space of Deci, so the things can pass easily into the hepatocytes, and from the hepatocytes into the what we call this sinusoids. So compare it with this is a normal structured lobule and a cirrhotic lobule. In the cirrhotic lobule, the pores are closed. So the fluid can pass easily into the hepatocytes, and you can see the dense collagen in the space of Deci, and the stellate cells become, these hepatic stellate cells, as we call it keto cells, their function is to store vitamin A. In a chronic inflammation and in cirrhosis, they turn into a myofibroblast. They don't store vitamin A anymore. They function as a myofibroblast. They produce cytokines and then they have this this contractile function. As you see, they are situated in the around the sinusoids. When they become a contractile function, they can constrict the sinusoids, and it is one reason of portal hypertension in cirrhosis. Just to remind the leaky gut, this is a normal gut with the tight junctions. Yes, we have microorganisms in the small and large intestines, but they are not allowed to pass the intestinal cells and into the blood in the portal blood. But sometimes, because of the food intake or something wrong with the microbacteria there, then the gut junctions are damaged, and the bacteria can easily pass into the portal circulation and then into the liver. So that's why we have to make our liver immune tolerant, so that we can handle this. အဲ့တော့တခါလေပြင်းပြင်းထန်ထန်မတိုက်ဘဲနဲ့ဒီချင်းလေးပဲ attack လုပ်သွားတယ် In that way, inflammation, we can avoid inflammation. Otherwise, connection of the other way, the liver will be inflamed. Okay. These are the routine liver function tests. By examining albumin, enzymes, bilirubin, or coagulation factors, do you think you can cover all the functions of the liver? And I cannot tell the functions, say, oh, we won't know anything. And yeah, the liver function test is a kind of misnomer. Liver function test, liver function will reflect a malona. That is the concept. Now, liver function, you keep it up. The liver here, bucket maybe there, or she's a bucket male, or the prognostication factors were fitted. Now, the low mark, Tigo, Kakeva. Liver function of Matina, Baotina, actually, liver status of the liver. This is a normal liver. Inflammation, inflammation because of the gut. We have power in the material, the GN doctor, water waiter, the changing, and the viruses, a xenobiotics, or immune mediated mechanisms, now, inflamed regeneration. It can be regenerated and it becomes normal again. But if you have a chronic, or prolonged, or a severe inflammation, it will end up in fibrosis. When the fibrosis becomes thicker, the fibrosis can be resolution to normal in the early fibrosis. In part 2, you have learned that once cirrhotic, you are always cirrhotic. Cirrhosis is irreversible. Now we know that in the early phases of cirrhosis, it is reversible. But if you come to a chronic state with massive fibrosis, then it is irreversible. Or hypertension will be added, and then there will be a progression of the liver dysfunction. You get an injury, and then you get a fibrosis, and then you get a cirrhosis. What I want to show you is that when the liver is injured, you stimulate the stellate cells, and the activated stellate cells become myoblastic cells, and they release extracellular matrix products, which is we call fibrosis, and matrix reconstruction, we have a fibrosis. Here are the cytokines produced during these processes. For the liver function, we are only doing ALT, AST, gamma GT, retromin, something like that. Actually, if we have the technology, if we can detect or we can measure these, we can predict the nature of the liver, the nature of the inflammation, the nature of the fibrosis more accurately. But it is coming. Oh, we can do it here, but in the other parts of the world, there is. So this is what we call it a cirrhosis. So this is a sinusoids, and this is there's a stellate cells producing all the cytokines, producing fibrosis, and then activating and the microfibrils and contracting, and then these vasoconstrictor substances are abundant, and vasodilator substance become less and less. So look at it, this is a normal liver, and these are the globules. Here in the cirrhotic liver, the arrangement of the hepatocytes become hepatocytes, and they are thick fibrous strands leading to nutrient absorption, disturbances in nutrient absorption and excretion. So that is what we call a chronic liver disease or cirrhosis. Whatever happens to the liver, either it regenerates, it becomes normal again, or it will come to the previous state, or it will land up in cirrhosis. That is the end stage, what we call it, end stage liver disease. The liver bacteria now so now cirrhosis bacteria. Cirrhosis, once cirrhosis is like that, the life expectancy is reduced. If there's a child C, the life expectancy is less than, the 5-year survival is less than 20%. So, cirrhosis means there's a, your patient will be shortened. So this is the cirrhosis liver. And not only the cirrhosis, yes, the cirrhosis has shortened the survival of the patient. On top of that, if you had a hepatocellular carcinoma, HCC, is added on the cirrhosis, then your life expectancy will be extensively lower. That is about months or a year. Why? Because the cirrhosis, as you have, so this is a chronic inflammation. This process is a slowly growing process for years and years and decades. In the hepatitis B, hepatitis C, we have neglected, or we can eliminate it. In the we have consumed alcohol, which is damaging the liver slowly and slowly, and the xenophytes. And now the most popular one is steatosis, fat. A fat in the liver. Yes, first it causes the liver dysfunction, but later on there is a fat toxicity, that is a chronic inflammation leading to cirrhosis and HCC. So the cirrhosis doesn't end by itself, it will progress to HCC, and if you had an HCC, then the prognosis, the patient prognosis will be very worse. So there is a direct effect. The direct effect means you directly involve the genetic mechanism, our DNA, integration into the DNA, and there is a mutation of the gene, and then it will become a mutant. Cells will become a focus of malignancy, and it will progress. Or sometimes there is an indirect effect through chronic inflammation. So if you can look at it, even in a fatty liver, there is a progression. Sometimes there is a rapid progression bypassing some of the stages, and then it will directly come into cirrhosis and HCC. What I am showing this picture is that if you look at it from the healthy liver to become a cirrhosis or HCC, it will take years or even decades. At least it will take about 10, 20, 30 years to become cirrhotic and then HCC. So there is a lot of time to prevent cirrhosis and HCC for our liver patients. But we have fulfilled that duty. Why? Because the liver is an immune tolerant organ. The inflammation is very mild. So the patient doesn't notice it. Nobody notices that the liver is inflamed or is under the inflammation. unless you test it voluntarily or deliberately, then you will know that the liver is in a state of inflammation. Or if more so, the liver is going into fibrosis. And the fibrosis is progressing, which would mean that it's going to be nearer to cirrhosis and then nearer to disease. So for a Titanic, if you don't want to collide with this iceberg, you have to return. The critical condition is more than, we need more than 100 yards to bypass this iceberg. Fine. They did notice the iceberg, so keep on going, and less than 100 yards, they don't have time to avoid the collision with the iceberg. This is the problem of the Titanic. For us, our liver patients, we are 10 to 10, 20, 30 years. And we know that if you have hepatitis B or hepatitis C or drinking alcohol or we're obese with a lot of fat, then we know that they will end up in cirrhosis. But we fail to take action. This is now the most valuable years, that is 10, 20, 30, even 40 years. We haven't done our duty of a healer. So the liver function tests are used to detect the presence of liver disease. If it is abnormal, yes, we can say that the liver is something wrong. And then we can distinguish between among different types of liver disorders, that is cholestatic liver disease or hepatocellular damage, or the extent of the liver damage, or we can do as a prognostication. I mean, doing serial, we can know that this patient is improving or deteriorating. The shortcomings of LFT, even when the liver is sick, or even the liver is inflamed, or even when the liver is fibrotic, it doesn't show in the liver function test. So the classification of diabetes, we can do a detoxification, at least respiratory function. Thus bilirubin is the most important to detect HC3 function. But the level of bilirubin doesn't reflect the level of liver damage. The liver bilirubin is very high. Patient is jaundice, is yellow, the whole body. But this prognosis may be good if it is due to cholestasis, due to blockage of bile duct. And if you can remove the obstruction, it can be good again. In a few days, it will be out of danger. But with a small rise in bilirubin, for a cirrhotic patient, it's a grave danger, very bad prognostication factors for a chronic liver disease, even for a little rise in bilirubin. So in CDB score, the bilirubin, CDN is child C, the bilirubin is, you can see it's not much raise, but they put it in the category of C, CPBC. So that's why when you are going to interpret the liver function, we have to do in collection, not only bilirubin, the enzymes, and the pattern of enzymes. And also we can do more like LDH, and even alkaline phosphatase. Yes, alkaline phosphatase is a marker of cholestasis. When the alkaline phosphatase is raised, we said there's an obstruction. Intrahepatic cholestasis or extrahepatic cholestasis. But we can even see it in normal people also. In old age or in a very young age, late in normal pregnancy, even we can see a non-pathological rise in alkaline phosphatase. Yes, pathological, it is intrahepatic cholestasis and extrahepatic cholestasis. And then it is also found in the bone. So we need to do an isoenzyme. Usually we do a 5-nucleotidase, or we can do a GGT to confirm that this rise of alkaline phosphatase is from the liver. And what about plasma proteins? They are what is synthetic function of the liver. And the coagulation factors are produced by the liver. And then with the added immunological tests like viral markers or these autoimmune markers, we can detect the etiology of the disease. And some tumor markers like alpha-fetoprotein, and without an imaging, we are not completed. And thanks to Dr. Sansangu, she has helped me a lot in the diagnosis and the management of my liver patients. Without it, we can't exactly estimate the damage of the liver, or the stage of the liver, or the cause of the liver. Others, we can do biopsy, but sadly, we haven't done liver biopsy in Myanmar for more than a decade. During my doctorate, I've done my thesis in hepatitis B and hepatitis D by doing serial biopsy. After that, nobody do liver biopsy. Now in the military, we are trying to train our pathologists and hepatologists to do biopsy. It is very important to manage the liver patient. Yes, the enzymes are raised, the bilirubin is raised. It can be raised due to inflammation. For the inflammation, we can use anti-inflammatory to overcome that. Or if it is raised due to fibrosis, anti-inflammatory can help in this condition. So by looking at the test, and if you are giving blindly the anti-inflammatory, is to a not a good practice. So we need a liver biopsy. We have to ask our pathologists to help us in that area also. So with this, I think you have some rough estimate. Whenever you are seeing a liver patient, and whenever you are reviewing the lab results, okay, do it collectively. What is the etiology? How much is the liver damage? And how to review them? Is he going to progress, or it has respond to the treatment? Or how long the patient is going to stay? Or what medications are we going to use? By looking at it, we can estimate it. Another thing is what now writing in chronic liver disease, there is a malnutrition, sarcopenia, and frailty. Malnutrition, you all know that. Undernutrition is a malnutrition. Overnutrition also is a malnutrition. In a chronic liver disease, the obesity, the high BMI is a dangerous due for the patient. Along with that, there is a defect in protein synthesis. The patient become sarcopenic. There will be less muscle mass. With this sarcopenia, the patient will become frail. That is, physiologically, he can stand the stresses. Now we come to discover that in a cirrhotic patient, if there is a loss of protein, then the prognosis is far, far more worse than people with a good nutrition. So these are definitions of malnutrition, frailty, and sarcopenia. And frailty is a physiological reserve and increased vulnerability. If you have a good nutrition, even you have a stressor or even a decompensation, you will likely to recover. But in a sarcopenic frail patient, once you become decompensated or if you had a stress, then it's hardly ever expected to be recovered again. So the sarcopenia and frailty is one of the most important things for a chronic liver disease patient. Assess that. Sarcopenia in flesh, and then we can do it by CT scan. That will be very expensive. So the clinical significance of sarcopenia and cirrhosis is that pre and post transplant mortality. There's a very high mortality, and then they are prone for hepatic decompensation. Quality of life is very much reduced, and they are prone to infections, and the hospital stay will be very, very prolonged. Papa will be happy. Another thing is, why do we have this sarcopenia and frailty? Because the plasma level of branch-chain amino acid in cirrhotic patient is deranged. This is the Fisher's ratio. In a healthy person, it is 3.9. In a decompensated patient, it is only 1.7. And even if you had a hepatic encephalopathy, you will have only less than 1. The Fisher's ratio is very important. What is the Fisher ratio? This is the ratio between aromatic amino acid and branch chain amino acid. This is a normal ratio. In a chronic liver disease, you have raised aromatic amino acids and less branch chain amino acids. If you can reverse that, then your patient has more chances of survival. So in the EASL guideline and ASLD and every authorities of liver, they recommend adequate nitrogen intake when you can eat by full diet. So we have to supplement. And the dose is 1.5 gram in 60 kilogram patients. So this is a dietary recommendation and protein for a clinical compensated cirrhosis because the severity of liver disease. Yes, before we have taught our students that in a case of hepatic encephalopathy, there is a high ammonia level because of, and the high ammonia level can be induced by high protein intake. So you are instructed to reduce protein intake in the case of cirrhosis with encephalopathy. Now this is totally changed. Because as you know, liver is a metabolic organ, it has to do gluconeogenesis. When the liver is sick, it can do gluconeogenesis properly. So the prolonged fasting or overnight fast is. So now I would like to continue to the future of hepatology. And the future, what will be our future? You can see this is the vertical farming. You don't need a lot of land spaces to cultivate. This is the vertical farming. So in hepatology, there are spheroids and organoids. We can beat the viral hepatitis still, hepatitis B, we can beat it. And all the autoimmune and other, most of the liver diseases, alcohol and fatty liver, we can beat it because there is no experimental organism. With some baboons, which are very expensive, so we can do research. But now we have these spheroids and organoids. These are the stem cells. We can cultivate these stem cells from one cells to a bunch of what you call hepatocytes, spheroids, organoids. So we can test pharmaceuticals or virtual agents, how we can use, put them into a environment of the virus, and then we can see the prognosis and see the progress of the disease. So this is the future. Might be one day we don't need a whole liver, or we don't need someone to donate the liver. We can grow these spheroids and organize, and then you can put it into a failed liver patient. It will be much easier, but it will take about a decade or so. This is Singapore has the technology to do it now. India has got it, Japan got it, US got it, Europe got it. We don't have it. Another thing is multi-omics approach in medicine. Now we are giving everybody, even is erotic, this is the formula, the treatment is formula. For every Tom, Jack and Harry. But biologically, Tom and Jack and Harry is not the same because of the genetics, because of the environment. They are different enzymes, different isoenzymes, and the different infection and different what you call prone to different diseases. If we can do genomics, proteomics, and then transcriptomics and metabolomics, we can tailor the treatment of the patient, or we can tailor the management of the patient, where the prognosis will be very good. So these are the new recoveries we are doing for hepatocellular carcinoma. We are doing local regional therapy, and now we found that when you do a local regional therapy, there are a clone of hypoxic resistant hepatic. These cancer stem cells they become dominate, and then there's a recurrent cancer again. So that's why it is very costly to let our patients go into cirrhosis. We should be managing the patient before cirrhosis, because we can manage ACC yet, although there are a lot of findings and new discoveries. And that is what we call liquid biopsy. Whenever there is a tumor, the tumor will be producing all these DNA, RNA, and the cytokines and the proteins. We have the means to measure these. We can detect them very early, and we can detect as a prognostication factors and our treatment response. This we call it a liquid biopsy, in contrast to our standard biopsy from the tissue mass. Just take a drop of blood and then you can measure. So that is the future of medicine. And in surgery also there will be a robotic. In liver transplant, the donor surgery is done by the robotic, 100% robotic surgery by living donor liver transplant. And they have programmed 70% for the recipient robotic. In the future, they will be seeing more of these. So that is the future. After that, I would like to tell you about our activities. Now I am serving as a president of the GI and Liver Foundation in Myanmar. And we have proudly launched guidance of ACC by our foundation last Saturday. We are going to have it in a short while. And then we are going to attend this Singapore Hepatology Conference. This year, this is a combined with the gastroenterology GIF Singapore, and we are going to have a 3 days, actually pre-conference and 4 days activity. Ryan will be coming with us, and then before that, I think I have invited a few, but nobody volunteers, so Ryan is the only one from the online going to this SEC. These are the last ones. We have go to the next 2019, 18, 19, and 2020. Almost 100 doctors we organize it, and then we take them to the conference where they had a chance to present cases, discuss with the world-renowned hepatologists, and then friendly visit to the hospitals in Singapore, and then making a lot of networking also. These are the group. After the COVID, we have to stop the activity, and 2023 only 4 CIE and only 4 can attend it. But this year 2024, we are going to attend. 71 doctors will be attending SAC, organized by our foundation and donated by the pharmaceuticals. TKSH Banaya sponsor. Okay, so this is AI. Last year we go to AIG Liver Conclave in Hyderabad. This is a 2.5-day section. One section, one speaker and 4 chairpersons. 90% of are Indians. The professors all are Indians. So I thought, how come it will be like a boring? But these professors are all over the world, from the US, all over US, the UK, and Australia, and then they are coming back, and then they are launching this symposium conference. So we are left behind a lot. And this is a MYANMAR team. We are nearly about 80 people, and so they gave us a good welcome. And then we have a special section, half-day section, only for the MYANMAR candidates. We have to visit the AIG and see what they are doing, and we have to do some hands-on also. This is a warm welcome. They have made a beautiful background for us. And some exchange of gifts also. So that's what we are doing. Why are we doing this? Because I would like to open the eyes of the junior doctors how medicine is practiced in the other world. And these are the guidelines we have produced. The hepatitis B, C, and C second time, cirrhosis, and now ACC. Now we are writing on hepatitis B, cirrhosis, and non-alcoholic fatty liver. They will be coming out. I think this year all will be coming out. Another thing what we have done is the international scientific meeting, starting from 2010. We have done every second year. We have done this is the second meeting. There's the third, fourth, fifth. All the renowned gastroenterologists and hepatologists all over the world. We had a good time there. But sadly because of COVID, after the 6th, we can continue. In 2020, our foundation had planned the 3 international conferences in Yangon. Among MYANMAR International Conference, 3 plan located. One is APASA, Asia Pacific Association of Liver, single topic discussion, elimination of hepatitis C, 2020. Very much another plan located. Another Asia Pacific, general liver cancer, primary liver cancer is one meeting with that. Pamadiman logo, plan located, and SASA, Myanmar Nash special joint symposium. Because of the COVID we have to cancel all that. But now we are going to resume it In December, we are going to this Asian Pacific Region for study of liver. We have a single topic conference for 2025. That will be in Lotte regarding about the current management of hepatocellular carcinoma. And thanks for your time, and now you know how much I care for you. The liver said, please treat me with tender loving care. I've done a lot for you. Please take care of me. Your second partner in ever loving liver is your liver. So please love your liver, and please love your patient's liver, and please don't waste time waiting for the disease to manifest, or so we have to do an active search and active management for we need to do active management for our liver patients. There's only one life on one liver, and there is a 1 million hepatitis deaths we should have prevented. So our foundation pledged to end world hepatitis in 2030, because almost every 30 seconds one people is dying in the world of liver problem. So let's join hands in eliminating hepatitis and then care for the liver patients with us. Thank you very much. Anything you want to add?
I was also thinking, I think I missed it, but when you said that when bilirubin goes high in a person who has a cirrhotic liver, does that mean there's a blockage of a counter tumour?
And the bilirubin is high, there can be a blockage of the tumor, or there can be a cholestasis, there may be a blockage of the vitro. It might be due to the regenerative nodules of the liver, or there is this liver synthetic function, or liver synthesis of bilirubin is very, very much reduced or defined. So that's why recently, because instead of cholestasis, because of the very little functioning liver mass, the bilirubin is raised, and that's why if there's another insult, again like a complication, like a decompensation, like infection or bleeding, then the mortality rate is very high.
အားလုံးပဲမင်္ဂလာပါရှင်။ညီမနာမည်ကတော့နန်းဆိုင်မှာဖြစ်ပါတယ်။ဒီအမှန်တကယ်ပဲ oral ရဲ့ business manager ဖြစ်ပါတယ်ရှင်။အရင်ဆုံး product အကြောင်းလေးမပြောခင်မှာပေါ့နော်။ဒီနေ့ CFP မှာအခြေပေးပြီးတော့မှတကူတကဆရာကြီး knowledge share လေးတွေလာပြီးတော့မှပေးပြီးတဲ့ brand ဆရာကြီးကိုအထူးကျေးဇူးတင်ပါတယ်။ပြီးတော့မှဒီမှာ sponsor အနေနဲ့ပေါင်းခွင့်ရတဲ့ပေါင်းခွင့်ပေးတဲ့ပန်းဆောင်ကိုလည်းအထူးကျေးဇူးတင်ပါတယ်လို့ပြောချင်ပါတယ်။ product အကြောင်းကတော့အများကြီးတော့မပြောပါဘူး။9မိနစ်စာလောက်လေးပါပဲပေါ့နော်။အဲဆိုတော့ညီမတို့ရှိမှဆိုရင်ဒါ Amino-Liver ကကြတော့ဒါ ideal solution ပေါ့နော် comprehensive therapy အတွက်ဆိုရင်တော့ဒီမှာ Amino-Liver က infusion နဲ့ oral ရယ်ဆိုပြီးတော့မှ2မျိုးရှိပါတယ် Amino-Liver oral ကကြတော့အဓိကတော့ medical food ပေါ့နော် hepatic impairment patient တွေအတွက်ဆိုရင် medical food အနေနဲ့ပေးလို့ရပါတယ်ရှင်ပြီးတော့မှဒီ Amino-Liver oral မှာဆိုရင်ဒါလေးကဒါကတော့ဆုံးမဆရာကြီးပြောသွားတဲ့ဟာတွေမှာလည်းအကုန်လုံးပါသွားတာဖြစ်တဲ့အကြောင်းဒါလေးကိုညီမ skip လုပ်လိုက်ပါမယ်။ဒါ sarcopenia တို့ protein တို့ရဲ့ definition ပါရှင်ဟုတ်ဒီအလေးကကြတော့ဆရာကြီးလည်း mention လုပ်သွားပါတယ် late evening snack ပေါ့နော်ဒီမှာ cirrhosis patient တွေမှာဆိုရင်သူက simple နဲ့ effective way address ဆိုရင်ဒါ late evening snack အနေနဲ့ပေးတယ်ဆိုရင်သူတို့အတွက်ပို့ပြီးတော့ကောင်းစေပါတယ်။ဒါကြောင့်လဲဆိုတော့ဒီ cirrhosis patient ရဲ့ဒီ cirrhosis patient ဒီမှာဆိုရင် sarcopenia ရဲ့ prevalence ကကျတော့ 40% လောက်ရှိတယ်ဆိုတာကိုညီမအရင် study တွေမှာဖတ်မိပါတယ်။အဲဆိုတော့ဒီ sarcopenia တို့ liver quality တို့အဲ့အဆင့်တွေမှာဆို prevent လုပ်ဖို့အတွက်ဆိုရင်ဒါကသူတို့ဒီ late evening snack အနေနဲ့ဒါပေးမယ်ဆိုရင်ဒါ patient အတွက်ပို့ပြီးတော့မှဒါသူရဲ့ quality of life လည်းပို့ပြီးတော့ကောင်းစေပါတယ်။ဒါကတော့ Amino-Liver oral ရဲ့ composition တွေပါ။သူမှဆိုရင်တော့ဒီ protein ရယ် carbohydrate fats နဲ့micronutrients ပေါ့နော်အစုံလေးတွေပါပါတယ်အဲ့ဒီမှာဆိုရင် protein ကတော့ branching amino acid က6 gram ပါပါတယ်ရှင်ပြီးတော့မှဒီ Amino-Liver oral ဆို Fisher ratio 38 formula နဲ့ထုတ်လုပ်ထားပါတယ် ပြီးတော့ preparation အနေနဲ့ဆိုရင်တော့သူက5 scoop ပေါ့နော်အဲ့ဒါ5ဆုံးကို180 ml warm water နဲ့ဖြောရပါမယ်ဒီတစ်ဖက်ဆိုရင်တော့သူက6 branching amino acid 6 gram ရမှာဖြစ်ပါတယ်ပြီးတော့ kilocalorie အနေနဲ့ဆိုရင်တော့210 kilocalorie ရပါတယ်ရှင်ဒီ amino liver oral မှာဆိုရင်အဓိက main highlight လုပ်ချင်တာကကြတော့သူက high protein ပေါ့နော် with branching amino acid ပါတာဖြစ်တဲ့အတွက်ကြောင့်မလို့ဒီ chronic liver disease လူနာတွေအတွက်ဆိုရင်တော့သူရဲ့ဒီ suitable nutrition အနေနဲ့ product တစ်ခုဖြစ်ပါတယ်နောက်တစ်ခုကကြတော့သူက high Fisher ratio formula အနေနဲ့ထုတ်လုပ်ထားတာဖြစ်တဲ့အတွက်ကြောင့်မလို့ဒီ branching amino acid နဲ့ aromatic amino acid ကိုသူက maintain လုပ်ပေးနိုင်ပါတယ်နောက်တစ်ခုက cis နဲ့ carnitine combination တွေနဲ့လည်းပါဝင်ပါတယ်ပြီးတော့မှ amino liver ကကြတော့သူကဒီproven clinical ဒီ paper တွေအနေနဲ့သူ publish လုပ်ထားတာတွေလည်းအများကြီးရှိပါတယ်အဲ့ဒါကတော့သူကပြီးတော့အဲ့ဒါကြောင့်မို့လို့သူက confirm efficacy in variety of chronic liver disease တွေမှာဆိုရင်အများကြီးသုံးလို့ရတယ်ဆိုတာကိုမြင်ရပါမယ်ရှင်နောက်ဆုံးအနေနဲ့ကကြတော့ဒါကတော့ amino liver infusion ဖြစ်ပါတယ် oral နဲ့ infusion မှာကကြတော့ Fisher ratio formula နဲ့ထုတ်ထားတာချင်းတော့တူတယ်ဒီ amino infusion ဆိုရင်တော့သူက 37.5 Fisher ratio နဲ့ထုတ်လုပ်ထားခြင်းဖြစ်ပါတယ်500 ml နဲ့ထွက်တာဖြစ်ပါတယ်ရှင်သူလည်း branching amino acid 35.5 weight by volume percent ပါပါတယ်ရှင်ဒါကကြတော့ chronic hepatic failure patient တွေအတွက်ဆိုရင်ပေါ့နော်ဒီ nutritional control မှာပေးဖို့အတွက်ဆိုရင်သူ hospitalization လုပ်နေတဲ့အချိန်မှာဒီ amino liver infusion ကိုပေးခြင်းအပြင်သူရဲ့ဒီ encephalopathy ကိုပိုပြီးတော့ improvement ရလာစေပါမယ်ပြီးတော့မှအဲ့ရနဲ့တူတူတပြိုင်နက်တည်းပေါ့နော် dietary therapy အနေနဲ့ဆိုရင် amino liver oral ကိုလည်းတစ်ခါလည်းပေးလို့ရပါတယ် discharge လုပ်သွားပြီဆိုရင်လည်းဒါ amino oral ကို prolong ဒီဆက်ပြီးတော့မှလည်းတောက်သုံးလို့ရပါတယ်ရှင်ဒါကကြတော့ဆန္ဒကညီမ highlight လုပ်သွားတဲ့အတိုင်းပဲ amino liver oral မှာဆိုရင်သူကတကယ် proof clinical study အများကြီးလုပ်ထားတာရှိပါတယ်ဒါအပြင်ဒါတော့နောက်ဆုံးfile လေးကတော့ဒီ liver frailty တွေမှာပေါ့နော်ဒီ frailty မှာဆိုရင်တော့ amino liver oral ကိုကျွန်တော်တို့ဒီဆန္ဒက preparation အတိုင်း50 gram မနေ့ညနဲ့ချိန်ပေးမယ်ဆိုရင်သူရဲ့ frail reversion rate ကို 16% အထိပို့ပြီးတော့မှ improve ဖြစ်လာတယ်ဆိုတဲ့ဟာမျိုးကိုတွေ့ရပါတယ်ဒါကတော့ဒါနောက်ဆုံးလုပ်ထားတဲ့ latest study လေးဖြစ်ပါတယ်ဟုတ်ညီမဒီနေ့ပြောချင်တဲ့ product အကြောင်းလေးကတော့ဒီလောက်ပါပဲအားလုံးကျေးဇူးတင်ပါတယ်ရှင်